Another complication that can happen during pregnancy that really affects the infant is Rh incompatibility. So this is what happens when mom has an Rh negative blood type and fetus has an Rh positive blood type. In general, the first child's usually unaffected, and what happens is the fetal red blood cells agglutinate or sort of stick together and get destroyed, causing anemia, hyperbilirubinemia, which can progress to bilirubin encephalopathy. This has dramatically declined since Rh immune globulin or RhoGAM. So what happens is maternal antibodies form in an Rh negative mother after exposure to Rh positive blood, called isoimmunization or sensitization. So we don't normally have those antibodies in our blood. If we're Rh negative, we have to be exposed to them or sensitized. And that usually happens at birth or when that placental membrane is compromised. It can happen with trauma, it can happen with an amniocentesis, it can happen with a spontaneous abortion. Anytime that placental membrane is compromised with childbirth, you have the risk of creating antibodies. So theoretically, during pregnancy, fetal and maternal blood is kept separate by that membrane. But, childbirth, spontaneous or therapeutic abortion, again, invasive procedures like the CVS or amniocentesis, trauma, any kind of hemorrhage or bleeding during pregnancy can cause that placental membrane to become compromised and mom can become sensitized. So what happens is the fetal red blood cells' lifespans are shortened, they clump together, they agglutinate, they break down really fast and get destroyed, and they can cause something called hemolytic disease of the newborn. So we have something we can do about it. We give moms RhoGAM. So you want to give it in the deltoid or ventrogluteal muscle. You look at the package insert when you do it. You're only ever going to give it to an Rh woman. You're going to explain the purpose and the need that she needs to have this done with every pregnancy. So 28 weeks or so, you're going to give an Rh negative woman RhoGAM. After birth, the cord's going to be tested. If your baby is a positive blood type, you're going to give mom another shot of RhoGAM within 72 hours. So it's indicated in Rh negative women who've been exposed to Rh positive blood by, again, childbirth of an Rh positive fetus, abortion of an Rh positive fetus, CVS, amniocentesis, intra-abdominal trauma, carrying an Rh fetus. So what it does is it prevents a permanent antibody response by suppressing mom's immune reaction. So you're going to give 300 micrograms IM at 28 weeks, and again within 72 hours of delivery of an Rh positive infant. You'll give a last dose if there is a termination of pregnancy or spontaneous abortion or CVS less than 13 weeks gestation. So special considerations I just have starred because you want to explain to people that it is made from human blood products. So, sometimes we'll have people of certain religions that don't accept blood products, and you need to explain to them, and you need to bring the provider in to explain to them so they have all of their risks and all of their benefits laid out in front of them. In general, Rh negative women, 28 weeks, they're going to get RhoGAM. Again, within 72 hours, if the baby is found to be positive, they will get it. Mother will get RhoGAM again. If she's found to be sensitized, so she already has those positive antibodies, those Rh positive antibodies in her blood, she would not get RhoGAM. They would watch that baby closely in utero. They would watch it after birth for any signs of hyperbilirubinemia or any signs of jaundice. So if she's not sensitized already, she's definitely going to get it. You always want to make sure that women that have abortions, that women that have spontaneous abortions or miscarriages, any kind of trauma, that they get it too. Anytime that placental membrane can be compromised, Rh negative women will be getting this immune globulin. It gives them the best chance of telling their body not to create permanent antibodies, so the next time they get pregnant, their body's not going to react, and their second baby, their third baby, has a chance to survive and not have an immunologic response. So there's another kind of incompatibility, which is ABO. So that's when a mom is type O and the fetus is A or B. So this is unrelated to the Rh factor. The first child can be affected, and you can't really prevent it. It's more common than Rh incompatibility, but it's less severe. So what you're going to do for either infant is phototherapy, and that helps conjugate bilirubin so the body can eliminate it. So in ABO incompatibility, mom's type O, she's carrying a type A or B baby. So naturally, people that have type O blood, they carry anti-A and anti-B antibodies already. So they don't have to be sensitized. They don't have to be exposed to it. We already carry it in our blood. So these IgG antibodies can cross the placenta and cause hemolysis of the fetal red blood cells, which is breaking down of the fetal red blood cells. So if a positive direct antibody test or a direct Coombs test is done on the cord blood, or there's early signs of hyperbilirubinemia, jaundice at less than 24 hours, you're going to treat that baby with phototherapy. So again, the main differences between an RH incompatibility and an ABO incompatibility is in our country, we have RhoGAM readily available for RH negative women. We give it at 28 weeks. We give it again if the baby is positive after birth within 72 hours. Mom's not sensitized. She can have, successful subsequent pregnancies. With an ABO incompatibility, there's not really anything that you can do. You can't prevent it. We already have those anti-A and anti-B antibodies in our body, but it's less severe. So those babies can still become jaundice. You're just going to watch them. These are the infants that are going to become jaundice in 6 or 12 hours, or immediately at birth because it's already been happening in utero. Most babies get jaundice. So most babies' livers are immature and they can't quite break down those red blood cells. So most babies do get jaundice, about 50 to 80% of them, but you're not going to see it for 2 or 3 days. When we're thinking a pathological jaundice as opposed to a physiological jaundice, you're going to see it within 24 hours. So you're going to see it, when you go in and the baby's 4 or 5 hours old and you already see the yellow of the skin or yellowing of the sclera or the whites of the eyes. And again, that's just that breakdown of red blood cells and that buildup of bilirubin. And why we want to check that and why we want to test that is because bilirubin is a neurotoxin and it can cross the blood-brain barrier and cause brain damage. So we check infants every 12 hours in the hospital. We check their bilirubin levels. We can check them by, visually assessing them, and then we check their levels and their rate of rise. And we would definitely carry out an order of phototherapy if there were any issues with either pathological or physiological jaundice, depending on what their bilirubin levels are.